Hi, my name is Tyler Smith, and I'm doing my report on Q fever. Q fever was originally discovered by a man named Edward Holbrook Derrick, who called it Q fever for query fever because he actually didn't know what caused it. Later on, a man named McFarlane Burnett was able to isolate it in a patient in Australia, and he named it Rixietta burnetii after his own name. And then at the exact same time, a man named Harold Ray Cox in the US, specifically in Montana, isolated it from a tick and named it after Rixietta diaporica. And this is because they both believed that it was part of the Rixietta genus, which was later discovered to be wrong by a man named Phillips, who renamed it Coxiella burnetii. He created a new genus for it and named Coxiella after Cox and burnetii after Burnett. A couple characteristics. It's a gram-negative coccoid bacteria. It's obligate intracellular, and it's pretty small. It's about zero point 0.2 to zero point 0.4 micrometers wide, and then about zero point 0.4 to 1 micrometers long. It's pleomorphic, and it's extremely resistant. It's pretty resistant to like standard disinfectants, UV light, osmotic pressure, and high temperatures. And so, quick overview of the pathogenesis. There's two different types of the Q fever, or the Coxiella. There's going to be the SCVs, which are your small cell variants, and your LCVs, which are your large cell variants. Your SCVs are going to be metabolically inactive, and your LCVs are going to be metabolically active. So the SCVs are going to be phagocytized into a macrophage, where they will survive inside of these CCVs, or coccoid-containing vacuoles. And they'll grow and mature inside of these, and eventually they'll begin replicating. And in some cases, there's going to be acid activation that leads to the formation of these LCVs. And so they will keep replicating inside of this vacuole, and eventually it'll become too many cells in there, so it'll erupt, and that'll allow for the cells to spread to other cells in the body. Overview of the transmission. It's going to be found inside of infected animals, specifically cattle, sheep, and goats. And it can be transmitted to other animals through, obviously, their children, so through birth or milk, and then other animals through contact of urine or feces. And then for humans, there's a couple methods. There's a couple rare cases where it's been transmitted through a tick to a human, or also through a tick back to an uninfected animal. And then through those infected animals, you can either get it through unpasteurized milk or dairy products being ingested, through contact with those birthing methods we talked about earlier, so the fluids or the placenta from the infected animal, or even just inhaling those contaminated dust particles. And then, because of those methods of transmission, the at-risk populations are going to be those who work around those animals, like farmers, slaughterhouse workers, or vets. And men statistically are more likely to contract it. It's hypothesized it's just because men are going to be working these jobs more often. And then people that are living in close proximity to those farm areas, the immunocompromised, and then older people, as shown in this chart here. As age increases, the incidences increase as well. For signs and symptoms, most, or about 50% of the symptoms are going to 50% of cases are going to be asymptomatic. There's two types of Q fever. It's going to be acute and chronic. Acute symptoms will be more mild, and they're going to develop about 2 days to 6 weeks after the initial infection. Mostly 2 days to 3 weeks is where it mostly onsets. It's mostly going to be flu-like symptoms such as fever, chills, nausea, vomiting, and then just general malaise. And in some cases, pneumonia and myocarditis can occur. And then in those chronic cases, which are going to be the more severe cases, it's going to develop about a couple months or even a couple years after the initial infection. It's going to involve an endocarditis, and it's going to be a bit more likely in cases with pre-existing conditions, such as like a heart valve disease or a blood vessel abnormality, or even like immunocompromised people, like I mentioned earlier. And in pregnant women, there's a special risk because it's actually been known to cause like miscarriages, stillbirths, preterm deliveries, or even low infant birth weights. So for treatment, the acute Q fever is able to be treated with antibiotics. It'll typically be given for about 2 weeks to just reduce those symptoms and then shorten the length of the infection. So non-pregnant patients are going to get tetracyclines, and then to avoid those side effects for pregnant women, they're going to recommend a cotrimoxazole for them. And for chronic Q fever, antibiotics are actually not effective at all. So they will be prescribed a tetracycline with a hydroxychloroquine, and this will be given until the symptoms are gone, which is typically about 18 to 24 months, but it's gonna be until the symptoms subside fully over time. And so the morbidity and mortality rates, it's gonna be a pretty low incidence rate, so it's about 1 to 30 cases per million. Overall mortality is going to be 1 to 2%. Low severe illnesses, not unless you have a pre-existing condition, it's not going to be a high chance of being hospitalized for severe illness. Chronic Q fever, which is the more severe one, is going to be about 1 to 5% of infections. And the rates of mortality are going to be lower if it's treated. As you can see there, with the endocarditis is 5 to 10% treated, and then vascular infections are 18 to 25% treated. But then those untreated cases with endocarditis are going to be about over 50% chronic mortality rates. And then the most notable outbreak for this was a 2007 outbreak in the Netherlands. There were more than 4,000 cases reported between 2007 and 2010. And this is speculated with current studies or recent studies that this is only representative 10% of the actual cases in this region. And if you look at this chart here, it was restricted to this mostly the southern region down here. There were a lot of high cases in this area right here. And that correlates with this other chart on the side on the right, where there's a very high volume of goats per kilometer squared, which goats are going to be a high carrier for this disease, so they'll transmit it to people around them. And it's spread to higher populations through these goat herds. And in 2009, it actually caused an increase of veterinary control measures. So they started vaccinating goat and sheep dairy herds, and they started improving hygiene procedures, and then this outbreak also just caused improvements in diagnostics and epidemiology networks. And final point, this C. burnetii is actually also it's able to be used as a biological pathogen. So the CDC actually has it listed as a category B pathogen, just because it's able to be sustained in a long period of time in the environment. Small amounts of the organism can cause an infection. As little as 1 and then around 10 is a safer number can cause an infection. It's highly resistant, as I mentioned earlier, to heat, light, disinfectants, and osmotic pressure. And just looking at these methods of transmission, there's aerosols, contaminated mail, food and water, blood transfusions, and sexual transmission. Those are actually more towards natural modes. But these aerosol, contaminated mail, and contaminated food or water, those are 3 pretty good methods of transmitting disease, and they increase the chance of a bioterrorism attack. So they've listed that as a category category B pathogen. And then here are my sources. Let me know if you have any questions.